So nice to have you all joining us. My name is Kendall Ho. I'm an emergency physician and a professor at UBC Faculty of Medicine, also the executive director of the Intercultural Online Health Network, or iCON. It's my pleasure and my honor to be able to open this Indigenous Health Round today. It's a joint session, joint collaboration and partnership between Vancouver Coastal Health Indigenous Health and also Intercultural Online Health Network, together with quite a few partners. And I shall name those partners a little bit later. But first, I'd like to open with a land acknowledgement. I'd like to acknowledge that the session today is occurring on the shared, unceded, ancestral, and traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. We're very fortunate today to have Dr. Terry Aldred, Lisa Montgomery Reed, and Dr. Michael Dumont joining us to talk about the First Nations Health Authority's strategies in primary care. We'll begin session first with our opening prayer by Elder Doris Fox, and then the presentation. It's my pleasure to introduce Elder Doris Fox. Elder is a Musqueam elder. Throughout the year, Elder Doris works at different wellness days as a life coach and healer, using various traditional healing methods taught to her by her elders and by Indigenous healers. Elder Doris sits on several advisory boards, committees, and Elder Circle. As well, Elder Doris worked at several health clinics as an elder and healer. Elder Doris Fox teaches various traditional arts and crafts, including traditional Salish weaving, cedar bark weaving, and beading that was taught to her by her elders. Elder Doris is an artist and clothing designer as well, and has taught sewing classes too. Elder Doris, it's our pleasure. Thank you so much for being here. May I hand the time over to you to guide us on this opening prayer. Elder Doris.
Thank you very much, Dr. Kendall. I swile meets up Quetquilum, eats and Hamasquilum and the Tolas Fox. Welcome everyone to the traditional unceded ancestral territory of the Musqueam people. We humbly raise our hands in gratitude to you for coming in a spirit of love, honor, friendship, and respect. We stand before you humbly and ask that you keep an open heart and an open mind during this session so that you can get the best and the most information that you can. When you keep your heart and your mind open, it removes you from any preconceived notions you may have, anything that may be stemming from ego, and allows you to just come from your heart, which is a place of love. And that's the best place that you can learn the most. We thank the Great Spirit for bringing us together in this imaginary circle this day. We thank you for coming, and we thank the Great Spirit for bringing you here safely. We humbly ask the Great Spirit to continue to protect each one of you, to protect you from all harm, including the harm we sometimes do to ourselves. We thank you for being here. We welcome you. We ask that the Great Spirit continue to watch over you until we meet again. And we thank the panelists for coming to share their vast knowledge, for sharing their heart with us so that we can learn the most. And I look forward to being a witness to this great session. And all those who are here to watch and be witness, being a witness is extremely important with my people. It means that when you go home, you share the knowledge of what you've learned this day with all your people in your circles, with your family, your friends, your coworkers, anybody that you come across, you share the knowledge. As my great-grandfather Manat said, knowledge is ours to share. It is not ours to keep. So welcome to everybody, and I hope you get a lot from this. Thank you. Thank you.
Thank you so much, Elder Doris. Really appreciate you helping us to open the session with our hearts open to receive the information that we have. I'd like to let everybody know that this session is being recorded, as is our conventional way. The reason for that is so that for those who cannot be here, that they will have an opportunity to be able to hear and learn from the sessions that we have. And so please be reminded that the recording has already started. The session will be started with our speakers. We'll be speaking until probably approximately around 12:50. We know that some folks may need to leave by 1 o'clock, so there'll be a good at least 10 minutes of Q&A. And for those who would like to submit questions, please use the Q&A part to submit your questions so that we can then use that for dialogue. Throughout the session, please type in your questions. Our panelists will present and then at the Q&A answer these questions. Our session will formally go to 1:30, by the way, but I know that some folks may need to leave by 1 o'clock. Really want to thank our partners, Vancouver Coastal Health, Indigenous Health, led by Leslie Bonjour, a tremendous partner working together on this. And of course, our First Nations Health Authority, part of the collaboration on this, and Ministry of Health with great support. And I want to thank Vancouver Physician Staff Association for their support of this session, and also within VPSA, our Engaging Physicians in Indigenous Cultural Safety Task Group, who help us plan this session. In this task group, I really want to thank our Indigenous patient partners, Cooper Jackson, Sherry Mercer, and also our members, Dr. Anis Latka, Dr. Chad Kim Singh, Dr. Don Wilson, Dr. Jay Slater, Dr. Shannon Turvey, Dr. Terry Aldrich, Kathy Olmos, and Sierra Roberts. I want to thank my iCON team, Betsy Lindberger, Karen Chan, and Alex Fung for organizing. We're so grateful for the foundational support of the BC Ministry of Health's Patients as Partners initiative, with whom we have developed a long-standing relationship over the past 10 years to advance person and family-centered care. The Ministry of Health continues to advance the shared journey of reconciliation, apply equity and anti-racism approaches, and address systemic racism in the health system. This is recognized in the Ministry of Health mandate letter that states that the ministry will continue working towards true and meaningful reconciliation by supporting opportunities for Indigenous peoples to be full partners in the inclusive and sustainable province we are building together. In this work, the Ministry of Health continues to address recommendations from the Truth and Reconciliation Commissions of Canada's Call for Action, UNDRIP, and the In Plain Sight report. For more information, please visit patientsaspartners.ca for free events and resources on person and family-centered care, chronic disease self-management, and caregiver support. I'd like to absolutely acknowledge our partners at Vancouver Coastal Health, Indigenous Health. VCH plays a critical role in the Declaration of the Rights of Indigenous Peoples Act, DRIPA, the Truth and Reconciliation Commission of Canada, 95 calls to action, and in implementing the 24 recommendations at the In Plain Sight report. Together, we're committed to celebrate Indigenous ways of knowing and being, to acknowledging the strength and courage demonstrated while enduring generations of atrocities, and to embedding Indigenous cultural safety across the healthcare system. We'd like to also acknowledge support of the Vancouver Physician Staff Association as we work together to engage the physician community together with all our health professional communities to build a more collaborative, inclusive, and caring community to support the best patient care, as well as First Nations Health Authority for the integral guidance and support, as you will see in this session today. Let me now introduce Dr. Terry Aldrich, Lisa Montgomery-Reed, and Dr. Michael Dumont. Dr. Terry Aldrich is the Executive Medical Director for Primary Care for First Nations Health Authority, the Co-Site Director for the UBC Indigenous Family Medicine Program, Family Physician for the Carrie Sakani Family Services Primary Care Team that serve 12 communities in North Central BC, the Indigenous Lead for the Rural Coordination Center of British Columbia, and an editorial board member of the BCMJ, BC Medical Journal. Lisa Montgomery-Reed currently serves as the Vice President of Regional Operations for the Interior Region in First Nations Health Authority. Lisa has previously served as the medical director, band manager, council member, and on many provincial committees. And Dr. Michael Dumont has previously been on this Indigenous round, and he helped to establish the Luma Medical Center in 2016, where he also serves as a medical director, as involved in teaching with the undergraduate and postgraduate medical training programs for the Indigenous Family Medicine Residency Program, UBC. He's also the vice president of the Indigenous Physician Association of Canada.
Good afternoon, everyone. My name is Dr. Terry Aldred. I'm Dr. Catherine Claston, a member of the Celia the Frog Clan. And I'm in this space as the Executive Medical Director for Primary Care for FNHA. It's nice to be here with you all. And I'm really excited to be able to share some of the work that we've been doing within FNHA around primary care and medical affairs, as well as really to hand it over to Dr. Dumont and Lisa Montgomery-Reed to talk a bit about how this framework and our concept has manifested with the services and programs offered through LUMA and the All Nations Healing House. And so, so these are the learning objectives of this talk, which was essentially to talk a bit about the primary healthcare transformation framework, as well as some of the key partnerships and initiatives related to establishing FNPCI/PCC framework and implementation of these First Nations-led primary care initiatives, and then to learn more about the holistic service models offered at those two centers. And so the context of primary care transformation and FNHA, and so for many years, the primary care provincial and regional teams help to support our regions and nations related to various primary care initiatives as an advocate and in more of a supportive role. And then over the course of time, it became evident that there was a desire for FNHA to help kind of support more as an operator as opposed to just a support through, say, other organizations or health authorities. And that really looking at it from two aspects around ensuring that we have FNHA, or First Nations-led initiatives, as well as continuing to help support other initiatives and the health system at large through other mechanisms or with our partners in various ways. And so kind of looking at it through kind of a two-pronged approach. And so, and so the FNHA, still a new organization, relatively speaking. We just celebrated our 10-year anniversary of FNHA being stood up in the province. And we serve over 200 diverse First Nations, as well as have an urban and away from home portfolio, and have really worked towards trying to break down some of those traditional silos that has existed in First Nations health. And so, and so this is our mission is for all for the primary care team to serve all First Nations people and their families in BC, including urban communities and those that are living away from home, to have access to quality, timely, and inclusive health and wellness services that are culturally safe, patient-centered, and closer to home. And so that's using both service models that have centers in rural remote areas, as well as offering outreach services and trying to virtually enable our initiatives as much as possible. And that these services are based upon Indigenous knowledge, beliefs, values, and practices that seamlessly integrate into both in-person and virtual care models, and that really address the holistic health and wellness needs of our First Nations people and their families. And so I like to think it goes kind of beyond a two-eyed model, where really Indigenous people's beliefs and knowledge and culture is embedded at the center. And then the kind of Western model and approaches are brought in to serve those core needs. So this was the primary care plus model that was done through broad engagement across the province to look at what would be an optimal primary care model for First Nations people and their families. And so looking at how these various circles kind of interconnect and build upon, and recognizing that there is bidirectional movement throughout the circles as well. But looking at, again, the individual, family, and community being in the center, and how we kind of wrap around or embed these services within that context. And so that includes the core wellness team and services like those offered at LUMA and the All Nations Healing House, as well as integration of community services, as well as allied health and social services, that we, again, build those seamless links into higher levels of care, like tertiary quaternary care, as well as other specialty services. And we've been building our specialist connections through real-time virtual supports, as well as the Rural Coordination Center, where we are kind of embedded in the real-time virtual supports family from the virtual services side, and as well as building upon those relationships to look at how we, again, kind of build that network of specialty services within FNHA. And the rationale, or the reason that we embarked on this journey, is because we have been told and shown that Indigenous people in this country do not have and have not had equitable access to culturally safe services that really meet their needs. And so when we look at documents like In Plain Sight, Reclaiming Power in Place, and the Truth and Reconciliation Commission of Canada, there are recommendations and calls to actions that look at embedding Indigenous wellness practices and elders and knowledge keepers into healthcare delivery. It's part of one of our fundamental rights as Indigenous people under DRIPA. There's also a call to increase representation of Indigenous people in all healthcare professions and spaces, and a number of additional calls to action related directly to health that have so far not been fully, have not been enacted, or at least not have been fully enacted. And so really looking at trying to establish kind of a benchmark where we can say, you know, in these spaces, we really try to uphold these recommendations and ensure that they're at the basis and core of what we do. And so with the First Nations primary care initiatives in particular, we have 15 of these centers going up across the province, 3 in each of the geographical regions of the health authorities. And this is a partnership between the Ministry of Health and the FNHA, and there's a shared commitment between FNHA and the Ministry of Health to advance the recommendations and rights outlined in DRIPA, In Plain Sight, the Truth and Reconciliation Commission, and the Missing, Murder, and Indigenous Women, as well as the LGBTQT plus Two-Spirit folks, which the MMIWG report and recommendations also address the various intersectionality of those individuals as well. And a component of the MOH's overall primary care strategy that aims to increase attachment and ensure high quality, culturally safe, and comprehensive care. And so these initiatives are being stood up alongside with the PCN networks that are going up across the province, which also have responsibilities to engage with and incorporate and collaborate meaningfully with First Nations across the province to ensure that those initiatives are also helping to address inequities in the care of First Nations individuals. And so we right now, as I mentioned, we have the 2 centers that are currently open with the hope of 13 more within the next 2 years. And so the FNPCIs are led by First Nations, so our regional teams really help to lead out on these initiatives in each of their regions, and to ensure that that all member nations are engaged, and that there's kind of fulsome engagement on where these centers will be, and this what services. So there is flexibility on what services that are supported and can be provided. And so really from the ground up, individual regions and nations can collaborate to determine, what would best meet their needs at this time. And one of really key components of these centers is that we do embed those Indigenous ways of knowing and being into the foundation of the models, and that elders, sacred knowledge keepers, and traditional wellness practitioners are key and equal partners in the overall primary healthcare team and strategy. And I think at this point, I could probably hand it over to, I don't know, Mike, do you want to go first and then over to Lisa?
Perfect. Miigwech, Terry. I'll just briefly introduce myself here too. Michael Dumont, Indigenous, Shonagan and Donjiba, Wabijeshin in Dodem, Hamasquim Squo Omish, Stalewatus Ninda. So my name is Michael Dumont. I'm Anishinaabe Martin Clan. I'm a member of Shawnigan First Nation. I also carry mixed European ancestry on my mother's side. And I'm very honored to be part of the rounds here again today, to talk a little bit more about LUMA's model and how we've found a really amazing partnership here with FNHA to build this model out as part of the FNPCI project. Thank you so much, Elder Doris, for your opening words. I always feel so honored and so humbled to share any stage with you or share any presentation with you. You always make me feel so grounded and so comfortable with the medicine of your words. So thank you for starting us off that way, and Kendall and Alex for the invite, and Terry for the invite to present today. So I'll share a little bit about Luma Medical Center. I think I did present at iCON, I think about 2 or 3 years ago, as part of a more broadly based Indigenous cultural safety talk with Dr. David Tu. We touched a little bit on sort of Luma's model then. So there, some of you may have seen a similar presentation to this before, but this one's going to go in a little bit more into our model and some of our guiding principles in terms of how we provide primary care in this space. Go to the next slide, Alex. So Luma Medical Center was started in 2016, and we were born out of a dream and a vision from our urban Indigenous community that very much guides us on everything that we do. But to build a primary care space, a medical center that would incorporate both traditional ways of knowing and the good aspects of Western medicine under the same roof, and to be certainly a place that was governed and owned by Indigenous people. And our parent organization, Luma Native Housing Society, has been working for over 40 years, providing housing and addressing the sort of social determinants of health and just generally looking after people in the urban setting here. But what was missing at that point was really this ability to more directly work on health. And so this space was envisioned as a safe space, a place where we really would focus on the tenets of trust building and relationship building and safety in healthcare. And again, integrate that with cultural understandings of health, with our own teachings and ancestral guidance around what health is, and pairing that with again the good aspects of Western medicine. So you see a couple acronyms at the bottom there. So the FNPCI, just as Terry was describing, the First Nations Primary Care Initiative. We're very honored to be sort of the first out the gate of these 15 Indigenous owned and operated primary care spaces in BC that are supported through partnership with FNHA and the Ministry of Health. And this partnership is really foundational for us. I can say this, with perfect certainty, we would not be open right now if it weren't for that partnership. Back about 4 years ago, we were really in a tough space. It's very difficult to run this type of a medical practice on a fee-for-service model, and that's how it started. We opened our doors with good intentions. We built this model out and really tried to operationalize it under that fee-for-service model, and it was not working. We were definitely quite in the red, and we were struggling to keep our doors open. And that partnership agreement and the good work that came from coming together, these two organizations really saved us. But we were able to build upon that model and really improve it through those initial visits and those initial negotiations with FNHA, and they were partners in building right from the very beginning. That took almost 2 years to get that from sort of a vision to when we actually did our signing and our announcement at an event with the Health Minister, Mr. Adrian Dix, on I get the date wrong here, but it was in September 2019, and with Richard Jock, the CEO of FNHA, and it was a really special day to mark that, and we've carried that work forward and continued to grow since 2019. We're also part of a local network. So we are one of the members of the First Nations and Aboriginal Primary Care Network. And that's a group of 8 Indigenous owned and operated clinics here in Coast Salish territory, Metro Vancouver, and then also on the Sunshine Coast. And this is a group of clinics that has networked together informally, but soon to be more of a formal partnership to support each other on improving the primary care for all Indigenous people who live in these territories. And so we take guidance from our host nations on that, and certainly play a role in terms of trying to operationalize those dreams and those visions that the nations have articulated for how care is provided in the urban space on their territories. Next slide, Alex. I'll give you a brief overview here on our sort of our panel, who we care for at LUMA. So we are located outside of the downtown east side. Most Indigenous, urban Indigenous organizations providing social services or health services in Vancouver tend to be clustered in the downtown east side, and we deliberately wanted to locate ourselves elsewhere in a more geographically safe place for families to engage with us. And I think that strategy has proved very effective. You walk into the clinic, it does feel, more like a home than it does like a sort of a sterile, cold, whitewashed walls sort of clinic space, the way a lot of clinic spaces are historically. We put a lot of care and attention into making sure the space feels safe and feels warm. We care for a population that's very diverse. So roughly 95% of patients at the clinic self-identify as Indigenous. We do have a criteria for self-identification to come to the clinic, but we take families as a unit. So there's many families that are mixed ancestry within the family, and so, for example, if it's a family where there are non-Indigenous parents, foster parents, and Indigenous children, we take that whole family as a unit, look after the care for those parents as well. So you'll see about 5% of our patients are non-Indigenous, but it's a mix in terms of status, non-status, Inuit and Métis. We have many people from territories within what is now BC, but many from over the Rockies and in other parts of Turtle Island. It presents a bit of a challenge for us in terms of how we provide cultural care and cultural services, because whose culture are we bringing into this work, and whose protocols do we follow, whose territory are we on right now? And we certainly take that guidance from our host nations, but there are people who are coming to us from further afield, from other parts of Turtle Island, who may be looking to connect with some of the medicine, the ceremony, the teachings that they feel comfortable with. So things like the sweat lodge, smudging, which are not necessarily teachings from this territory. And so we have to connect elders and knowledge keepers and traditional healers from other places to our community here, because we have over 300 nations represented. That's roughly half of all the First Nations in Canada represented within that 2,400 patient panel, and well over half of the almost 3/4 of BC First Nations represented there too. Next slide, Alex. So I'll briefly present sort of our 8 sort of big picture strategies. This is what we've drawn upon in terms of how we came up with this model. I spoke a bit to that geographic safety. The second part there around trust is so important, and I certainly, I think this audience is well aware of the work that came out of the In Plain Sight report, the guidance of the TRC and UNDRIP. There's a well documented history of as far as how our healthcare system has caused harm to Indigenous communities, and why there is a legacy of mistrust. Why many of us walk into healthcare spaces with a sense of apprehension and a fear that we're going to be discriminated against. So we had to work really hard in terms of creating our space so that it didn't perpetuate that same feeling of mistrust. Part of that goes into hiring Indigenous people. We have a hiring policy that certainly prioritizes the hiring of Indigenous healthcare practitioners, allied practitioners, and administrative staff. Part of it goes into the way that we do our work. I'll speak a little bit to that in some of the future strategies here, but a lot of that trust comes down to this being an Indigenous owned and operated organization, and we are arm's length from government. We're arm's length from the health authorities. We are an independent functioning community. We have a community board of all Indigenous board members. So we are a little bit outside of that system, even if we still have those strong partnerships within the system. You'll see from some of the pictures here in the next few slides, we've done a lot of work in terms of the design, the outside of the building, the structure of the building. It's designed by Patrick Stewart, who's a Nisga'a architect, and our CEO, Marcel Lawson-Swain, who's Cree from Northern Manitoba, from Norway House. He did most of the interior design work, and you'll see some of the color scheme here. It just is a really nice, warm feeling when you walk into the building. We have beautiful sacred spaces for ceremony, for medicine, and I think I covered most of the rest of that already here. So next slide, please. This is a big part here, that first impression. So we put a lot of effort into training our staff and the learners who come and work at our clinic to really take advantage, take that opportunity to really make a good first impression and help people build the foundations of a good therapeutic relationship. We try to have longer time for our visits. We have 30-minute standard visits. Many of our visits go much longer than that. And sort of a welcome appointment may look like several hours. They'll be initially connecting with the registered nurse, then connecting with the family physician or the nurse practitioner who's going to have that MRP role. But then they may see one of our elders, or they may see one of our counselors later on that first day. And so it's a process of building those therapeutic relationships with the whole team, and most of our patients will interact with multiple team members on a given day when they come in to see us. We do try to break down some of those barriers in terms of communication, explain things in plain language as much as we can, as people leave understanding what their health concerns are and what it's not just a prescription or a referral. Without a lot of those questions answered, we really focus on trying to help people understand what's going on, focusing on a more balanced approach to health, incorporating physical and mental and emotional and spiritual elements of the care we provide, and then trying to bring in as much as we can in-house. So that model that Terry was showing you there in terms of the primary care plus model, a lot of those concentric circles, we've tried to bring those in within the primary care space. So allied health, social services, we have social navigators who are part of our team who can help with a lot of those things. We aren't referring out to other agencies to support people. Those are integral members of our own team. We have a midwifery team to be able to help provide prenatal care. Patients can come, they go to the same patient rooms, the same visit rooms that they would for a doctor's appointment or a nursing appointment to see the midwives. So it's already a place that's comfortable and safe for them. We have on-site phlebotomy and blood collection. We have pediatricians and psychiatrists who consult with us. We have a dietitian on our team, a foot care nurse, massage therapy, hoping to get physiotherapy soon, and a pharmacy as well. So we're trying to be a one-stop shop as much as possible. Next slide. We do focus a lot on children and youth, and generally, trying to be an inclusive and safe place for families. So again, we do have 2 partnering pediatricians, including the only Indigenous pediatrician that I'm aware of right now in the province. There's a couple in training, but 1 practicing. And we do have partnerships and good relationships with VACFAS and MCFD. And we often will have an advocate or sort of intervening role in trying to help support family preservation on difficult cases when they come up. We have family and youth focused groups and workshops, and just generally a focus on trying to support the most vulnerable people in our entire community, which are the children and youth growing up in care. Next slide. We also have a strong focus on social determinants of health. Those social navigators I was talking about, those are social workers by trade, but they work for us and they work more directly as advocates for the patients. And so their role can span many different aspects of social health. It can be could be supporting somebody with a housing application. It could be supporting somebody to try and get some ID that they've lost, or apply for their First Nation status if they haven't been able to do that. It could be something more along the lines of supporting a Jordan's Principle application, looking for resources in terms of social services for youth, for example, that's recently been diagnosed with autism, trying to connect with those other social services that tend to have fairly high barriers in terms of accessing. Really helps to have a navigator who understands that system. So our navigators help a lot with that. Those are things that I'm not very good at as a family doctor, and I think a lot of my peers struggle with too. So we have experts who know that and do that as part of our team. Next slide. As part of this network, we've done a lot of work in terms of how we collect information, how we keep that confidential for our patients, which is a big concern, I think, everywhere, but an even bigger concern in the Indigenous community, where our circles are small and there's always that fear that somebody's going to learn something about your health information that's maybe a little too close to you, right? So we have robust agreements for confidentiality with all of our staff, but we are collecting information both on wellness and on illness, and we're really trying to have more of a strength-based approach to how we collect this data and how we report it, more in line with how we collectively, I'd say, as Indigenous people, not to pan-indigenize, but I think we have more of a wellness and strength-based focus in terms of how we think of health and how we define it, more in terms of balance than perhaps a lack of illness, for example. And this is part of how we, I think, have justified and made successful applications for more services, especially in the area of mental health within our panel, or in our model. Sorry. Next slide. We do have a strong focus on teaching in the clinic as well. So we're very proud and very excited to be a learning site for Indigenous learners through the Indigenous Family Medicine Residency Program, Indigenous and non-Indigenous allies as well, I should say. So we host residents as one of their home sites for their training if they're in the Vancouver program. And we also have a number of medical learners who come for electives at our site too. We're trying to grow that out as we have more doctors working who can take on the students and learners. All of our medical practitioners are UBC faculty, and several of us have teaching roles and do more didactic teaching as well as the clinical teaching in the clinic. We are a training site for Indigenous nurse practitioner student practicums, as well as social work students who come through NVIT. Next slide. This is just to speak to a small piece of the cultural aspect of healing that we incorporate into the work that we do here. That picture there is Elder Saislam from Statliam territory, one of the elders who works with us, and we really this is really at the core of what we do. In many ways, the work that I do as a doctor is really second to creating a space for this sort of work to be done. We do have a sweat lodge in the back of our clinic now. It took many years of permitting and getting that through the fire department and several other departments at the city of Vancouver, but we're really happy that sweat lodge is now open and operational. We have a space we can do smudging pretty much anywhere in the clinic. You'll hear drumming, most days when you walk in, you'll hear that. We have workshops and on making and preparing traditional medicines, gathering traditional medicines, out on the land, as well as workshops for traditional foods and other aspects of what we consider medicine. There are we know from sort of more Western-based research that traditional healing practices are associated with lower anxiety and depression scores, lowered blood pressure, and a reduced use of tertiary care services. So these are things that our sort of more Western-based healthcare system can also appreciate. These can save money. These initiatives can actually help improve the care. This is not an additional. This is not like a little bit of sweetener to add to a primary care model. This is integral. This is right at the center of what we do, and it's something that helps people stay well and become well. Next slide. And then lastly, I just wanted to speak about permanency and partnership. That relationship at the center of this between practitioner and patient is so important. And all of those horrible experiences that we've seen exemplified with stories like Joyce Echaquan's, Brian Sinclair's. These are things like, how do we make the system safer? How do we respond to those horrible stories and the broken relationships that those stories represent? We have to build good relationships, and every small example of a good relationship between an Indigenous person and a healthcare practitioner helps to change the system that we're all part of. And so we have a responsibility, I believe, as a system to try to create as much permanency and as much of a longitudinal sort of aspect of that relationship as we can. So we want to treat our staff really well. We want to make sure that they want to stay and they want to do this work long term, so that those relationships don't get interrupted. So that's a big part of what we've done here with our model, and tried to make sure that we are competitive in terms of the pay and benefits that we provide for our whole team here. And that's minimized staff turnover, I think, more at our clinic than it might have at some other sites, and certainly more than it was before we had that partnership agreement with FNHA. And I think I've gone a little bit over here, so I will graciously pass it over here to Lisa, and I'm really excited to hear what Lisa has to say here too. Miigwech.
Just as we're waiting to upload the deck, YEP Snexil and Cha Squeeze Chakakusant. My English name is Lisa Montgomery Reed. I reside in the Okanagan and live in my home community of the Lower Smilkameen as part of the Silks territory. I just want to thank you for the invite today, and thank you for my colleagues' opening presentation and Dr. Kendall Ho for inviting us. It's so exciting to talk about Indigenous health, and for there to be such a forum as this to have a space to answer any of the questions that you have as we continue to learn in this space and break true ground for Indigenous health. And so today I'm here to talk about the All Nations Healing House and in our journey. Next slide, Alex, please. Terry's already gone through multiple slides, so we'll just go right to the All Nations Healing House. Perfect. We can go, this is a bit of a joint deck. If you can keep going, Alex. One more. Oh, can you just go back a slide? When I presented this, I work in the interior region. We're aligned with the Regional Health Authority, and I have to show this because our All Nations Healing House is located in Williams Lake. And if that picture of the horses and the buggies don't say it all in terms of this being nation owned, I don't know what will. And so how many of you have gone to the Williams Lake Stampede? And we work with 12 communities in the area. And this just shows how much it's owned and operated by our people for our people. So I just had to share that slide because that was done just a few months ago. So thank you, Alex. Next slide. So our slide, and I'm going to go quick here. Our healing house is actually operated by 3 nations. So you'll see the list of communities, from the Secwépemc communities to the Chilcotin Nation and to the Southern Dacal nations as well. And so those are the listed communities. Next slide. And our journey started in November 2016. And when we talk about truth and reconciliation, it started with a complaint around culturally insensitive care at the hospital in town. And then from that, it helped us move forward with our partnership with Interior Health Authority around a culturally safe solution to healthcare in Williams Lake. So our engagement started in 2019, and 2020, we started engaging with our 3 nations. And many of you that may or may not have worked in First Nations communities, there's a lot of cross boundaries amongst our nations. And for 3 nations and 12 communities to actually come together to design and operate a center is quite fantastic. Many of you may have worked within municipalities. And for us, this is 12 governments working together on a common vision for better care for our people. We also engaged with the urban and away from home members. And even having said that, our leaders will say there's no boundaries. It doesn't matter where our people live. We need to look after all of our members. Next slide. So as we move forward, the foundation of how we work is really based on ceremony and tradition, as was noted in the Luma Center. And the model was about enhancing services. So there's many tiers of support, from community funding agreements to nation. We're really nation-based in the interior region. And so this was to address those further gaps and capacity needs within the area. Next slide. So, you know, the interior region, we get hit a lot in terms of climate change. And so we've had multiple compounded trauma within the interior region as amongst all of our people across Canada. And it started in 2017, 2018 with the wildfires, as well as the showing of our missing children from St. Joseph's Mission, as well as to Kamloops to Secwépemc. And so the need was clearly indicated, and that's why we started in Williams Lake with All Nations Healing House, which at first was called the Williams Lake Center, and then it moved as the elders defined the name. We had all the elders come up with All Nations Healing House as the title of our primary care clinic. Next slide. So this is what I was talking about, is that naming ceremony. So when we were there, and I'm such a storyteller, the All Nations Healing House sign was actually covered over. All the staff had stickers over their shirts, and I was like, why? And I had chiefs coming up to me and saying, why don't we know what the name of this is? And it was actually the elders that you see in the photo in front of you that decided the name. And it's so fitting because, again, you have 12 communities, the members in Williams Lake deciding what the name is. And we have that in all 3 languages within our center. You can see the amount of people there in the opening. And that was the actual opening was in November, and then we had the naming in June. Next slide. So we have multiple staff working together, and you can see Snowy Williams Lake there. Our approach is really that wraparound. We have physicians, MOAs, mental wellness clinician, traditional practitioners, wellness coordinators, and navigators. And we're the first rural clinic. And many of you that may be on, in terms of rural, you know, it's quite challenging. We also have the challenge of, as most of you, of trying to access and recruit GPs and MPs. This truly is true reconciliation with a safe space for our members. And that's really the vision as we continue to move forward. Next slide. So I have a couple of, you know, I can talk all I want, but it's really the people that come to the center that I wanted you to hear.
Let's start from the beginning. I had no doctor at all for 3 years, nothing. And I have a lot of medical issues. I'm a diabetic. I've had 10 abdominal surgeries. I'm in kidney failure. And being without a doctor with all of these huge medical issues is really not good. I'm probably lucky I'm still alive. I ended up in the hospital with massive infections and no treatment after you get out of the hospital. You're kind of like on your own. And then what do you do? So I was really thankful when I heard about the Healing House coming and opening, and that I had a chance to get a doctor. But for the first 6 months, because I hadn't registered, because I didn't know, I had to do the doctor of the day, which is I would come here and sit with the nurse, and she would take my blood pressure and my sugar levels, and she would answer any questions that I had, or she'd write the questions down so that we didn't miss them when I got to do doctor of the day. And it was so great because they had the computer screens there, the doctor could see me, the doctor could ask the nurse Serena to take whatever things she wanted to know about. Like if she wanted, she would squeeze my fingers sometimes and ask for the, you know, how long it took for the blood to come back. She did my sugar level, she did my blood pressure, because I was suffering from extremely high blood pressure. It was like 231/80 or something. It was like way over the top. And so the doctor would tell Serena what to do, and Serena would do it, and she would tell me, you know, what else. She booked me in for foot care, which for a diabetic, huge. I haven't got there yet, but I'm on the list, and at least I'm on the list. So without this place, that's not accessible for me anywhere, because I don't have a family doctor anywhere else. So I now have a steady family doctor, Dr. Patterson. I love him. He is so attentive. He's been so great. He's really on top of all of my medical needs. Right now, my blood pressure has stabilized, and my blood sugar is still a little bit high, but we're working on that. But I've had this serious neck pain for over 3.5 months, and we've gone through all of the normal things, like he sent me for massage therapy, and then he sent me for some x-rays and a CT scan to rule out everything. And at the end of the day, he figures it's probably nerve damage. So he's trying out a few different medications for me and getting better slowly. So I'll see him again in a few more days and we'll go over it again. But it's been amazing. Like, without this place, I'd be in trouble. And I'm thankful. Thanks.
I know we're running a bit behind schedule, so I just wanted to speak about, you know, when I talk about safe care, and we talk about the showing of the missing children into Kamloops, Secwepemc, and St. Joseph's Mission, for people to even walk through the door in a safe space is what FNPCI is all about. And we're really working hard, and next time, you know, we'll share the video with our elder here. but it's really about that holistic care of being able to provide both streams of care of who we are. And I talk about being scaled, it's who we are, and it's what's been taken away from us. And these centers provide that safe space. And we have children's hands all across the walls. It really is a family space when we talk about our spiritual wellness as well. So I won't go into any further than that, but it really is impactful. And to see those grannies, and some of our people don't leave our communities when we talk about rural, and many of them still speak our language, our traditional language at home, and they feel comfortable coming in, and they are the true boss of our primary care clinic. Next slide. So when we talk about, and I'm not sure if Terry will talk further about this, but our medical affairs office, I think it's important because one of the things I continue to advocate for with the Ministry of Health is really that infrastructure. So First Nations Health Authority has been in place for 10 years, and needing that infrastructure in which Terry's team provides around the medical staff, the recruitment, the onboarding, and just the continual clinical oversight has been huge for our organization, and providing that partnership and keeping our clinic to a standard in which our neighbors have across the street has been such a huge impact. So Terry, I'm not sure if you want me to turn it over to you further, or if we've run out of time. So I'll leave it at that. And I just want to thank you again. You know, one of the pieces of work that we are working on now, you know, we have standards, you know, GPs, NPs, nurses, you all have standards, you know, and our history is oral. So when we talk about providing traditional wellness in our clinics, we're really having to work on, you know, what are we paying? What's a safe method? How do we ensure that the member that's coming in has the opportunity to provide and receive traditional healing, and the liability that comes with that. So we've had to think differently from our oral history, and really look at a process so that we can keep all members safe for accessing traditional wellness as well. So I'll end there. Thank you, everybody, and I'll be here to answer any questions. White Lim Lim.
Thank you so much, Lisa. I wonder, Terry, shall I pass it back to you first for some remarks before we break open for the Q&A?
Yeah, I mean, I can be really brief so that we can leave more time for questions, but thank you, Lisa, for the kind words. You know, I think as FNHA, we're moving into this space. We've been doing a lot of designing and planning, and then in the case of Luma, and which was our first and our scale up, and Williams Lake, our All Nations Healing House, which was our first net new. You know, it's really launched us into like looking at design and implementation, and then that kind of ongoing planning and support. And how we do that with our medical staff is also very important. And so I think as still a relatively new organization, and then entering a new space with service delivery, we've definitely been on a huge learning curve. But I think what these centers for me speak to, and what I've shown, is that when we actually put Indigenous ways of knowing and being in the center, and are truly nation led, and keep those principles at heart, that we can really produce places and spaces that really meet the needs of First Nations clients and their families.
Wow, wonderful. Thank you so much, Terry and Lisa and Michael. Really excellent presentation. We have quite a few questions in the Q&A, so I'm going to jump right to it. I want to thank the audience, not only first acknowledging great presentations, thank you to our panelists, also powerful videos, Lisa, that you've shown. So really appreciate that a lot. First question, Yvonne asked, thank you for that. I'm going to combine the first two questions into one, and that is for these centers and also First Nations Health Authority. For Métis community members, are they able to participate? Are they able to have those access to those services? What are your thoughts to that question?
Yeah, thank you. It's actually a very timely question, as I very recently it's been surfaced in other spaces as well, and so my understanding is that it is open for all Indigenous people and their families, both our virtual services and our FNPCIs. Not to speak for I see Dr. Dumont has his hand up, so I can let him clarify. I understand that the language still used as First Nations individuals and their family. And I think that there have been some conversations around how we address or look at that language. And I think just given historically that FNHA took over the services from the NIHB, from the National or Federal Department, which were exclusively for reserve patients. But looking at over the course of years, understanding that, half of our population does live in urban and away from home locations, as well as that there's Indigenous people from across Turtle Island that reside in BC, and that we really wanted to build the mechanism to kind of break down those silos and really, and try not to create more barriers. And so I think we're still just kind of working through what all of that means, especially with the various funding streams, which can sometimes still be very siloed. So at this point, my understanding is it is intended for all Indigenous people and their families. Mike?
Yes, strongly agree. So as far as Luma's concerned, if you're part of the clinic, then you're welcome to use any and all of the services that we provide in the clinic, and that's for all self-identifying Indigenous people, status or non-status First Nations, Métis or Inuit, and their family members.
Thank you very much. Next question is from Neda. Thank you very much. Neda's wondering, are there more Luma type primary care centers? And of course, also, Lisa, thanks for the health centers. And also a related question later on is the other centers, the other FNPCI centers, where are their locations and what are your stages of opening over the next 2 years? Anything you can share with us on that front?
This is where it'd been great to have somebody from our central primary care team. So I'm definitely not going to remember all of the locations just off of the top of my head. But as mentioned, so we have 3 that's situated within each of our regional teams. So and our regional teams follow roughly the geographical regions of our regional health authority partners. So we'll have 3 in Vancouver Coastal, 3 in Fraser, 3 in Interior, and 3 in the North, and 3 on the island. On the island, I believe there will be 1 in North, or Alberni and West, and then 1 mid-island, and then 1 South Island. In the North, we have 1 in each of the Northeast, North Central, and Northwest. I think 1 in Wet'suwet'en, 1 in Fort St. James, and 1 in Chetwynd area. Lisa, do you want to speak to the Interior? You probably know them.
Yeah, we're in the our PAR has just been approved by the Ministry of Health, and we're planning in the Statlium territory and Lillooet, and then we're doing a hub and spoke approach in the Lytton area and the Merritt area. So those are our next 2 projects that we're hoping to be soft opening within about 13, 14 months is our hope.
Thanks, Lisa. And then Luma is one of the ones in Vancouver Coastal. And I'm unsure off the top of my head where the other 2 are planned. And then in Fraser, I believe they are looking at, again, through Fraser South, Fraser West, and Fraser East, I believe. And I think 2 of them will be kind of hub and spoke, doing outreach to the various nations. And then 1 will be a main center.
Wow, so
I
exciting.
can speak to Coastal. I believe Coastal will be in Southern Statlium, so near Mount Currie, Pemberton area, and I believe the other one will be in New Hawk Territory, Bella Coola. And then I know one of the Fraser Health sites would be, it's actually quite far along. I think it might be the next one ready to open is at Chehalis, in the eastern side of the valley.
Wow, very exciting. Looking forward to these centers opening and also sharing their experiences and we learning from them. Thank you. The next comment is from Kate. I'm wondering if there are any partnerships or relationship with nations that are trying to gain child welfare, or perhaps to share lessons learned with health-related ministries. Welcome thoughts on that.
Sorry, Kendall, can you repeat the question?
I think the heart of the question is perhaps considering child and child welfare and also lessons learned from health-related ministries. Are there ways that we can bring those learnings together?
Anybody want to take a?
Yeah, I can. I think that's a really good question. You know, so many of our structures are so siloed, whether it's education, child welfare, and whatnot. And I think there is a lot of opportunity in terms of those, the landscape of prevention and promotion, the mental wellness program, but also more so integration, especially when we look at traditional wellness as a core key component of the work that we're doing. I think it's really important that that be part of our operating model in terms of partnerships and understanding of the scope of work that happens so that we're not duplicating service, that we're complementing each other.
Excellent. Thank you, Lisa.
That's beautiful, Lisa. I strongly agree with that. And I think it just speaks to the need for us to try to co-locate and bring these services as much as we can together. I even just from thinking of some of the cases where you know, cases where I'm consulting for a child or a youth, where there are some concerns in terms of the living situation, and when we do need to communicate with our partners in MCFD or elsewhere, it just helps so much when you've got people in house who have more of an expertise in that area. Our navigators at the clinic, one of them has, experience previously working as a family preservation worker with MCFD. And, when you have somebody who can act as an advocate who really understands how the system works, as part of your primary care team, as part of that health team, it takes away some of those barriers and helps to de-silo, I suppose, how we approach these things, because it's not separate for that human being at the middle of it, and for the community and the family that are struggling. It's health and social services are not separate things. We need to be thinking of them together.
Excellent, thank you. This is a question on the chat that was asked around 12:48. Miriam asked, and that was, I think, around the time that we were talking about LUMA, but also, Lisa, welcome your thoughts about your clinic. Is there a mobile team associated with your centers? And are elders and young families able to receive home visit from your centers?
I can speak to LUMA. So that is something that we are doing in a small way at this point, but certainly want to expand. And it's mostly through our registered nurses, who are doing some home visits for homebound patients and others who struggle to actually physically make it into the clinic. It's also something that we are planning with our future pharmacy project to be able to do deliveries, and for the nurses who would eventually be doing some of those deliveries to help with some basic assessments of clients when they're there doing those deliveries. So we're at the early stages of really operationalizing that and building that into our model, but we're already doing it in a small way. Yeah, that's a LUMA.
Yeah, for All Nations Healing House, we do have transportation as part of our approach, and ours is kind of unique in terms of the traditional component. So taking some of our urban members and picking them up and actually taking them to on the land initiatives, whether it's in the Chilcotin territory or if there's a sweat in the Schwetmik, there's lots of those opportunities for our members to actually participate out in community, as well as the members coming into community. So it's a reciprocal partnership.
Excellent. Thank you. Claudia asked, what was First Nations Health Authority criteria for selecting the current clinics? And are there abilities of all First Nations able to apply for this very needed resource pathway downstream? Welcome to your thoughts.
I can start, Terry. I don't know how many of you have worked for First Nations communities, but it's quite a political landscape. But for us, for Williams Lake, just to start there, because of the discussions with our leadership with the province, that and the racism that was happening in the local area, that's how that clinic was initially decided. Each of the regions have regional governance structures, and we have a governance terms of reference that is approved by our 54 chiefs and leaders in the area. And so some of those boards are set up to support some of the decision-making framework. I would say that our hope is that this is just the beginning. Our hope is that we can open our doors and be ready for others once we show that these have been successful. So each region has a position, like myself as a vice president, that is, and of course, Terry, and we have a VP of primary care that is there to connect and have those doors open for future opportunities.
Thank you very much. There's a question about the Luma Medical Center structure. I think Terry. So I'm going to let Terry complete the answer there. Thank you very much.
I can.
Oh, do you want to speak to it?
I can just. Sorry, I was like writing this big long thing. So the funding model for these are very similar to the PCNs, or based on the PCNs, with some important adaptations for the Indigenous health context. And of course, over the course of the last few years, we've also been helping to continually to shape and inform as much as we can as we hear concerns or have or questions that are raised from our host nations and regions. And so, so there is a fixed amount, and they will be, but there's flexibility on how that amount is applied. So, and that's largely done through our engagement with host nations, so that they can kind of be able to determine which service providers will most meet the current needs. So, for example, if they really want to focus a lot of it on mental health, for example, they can, or if they want to bring in physio or occupational therapy, they can, as well as an MRP, like a physician or a nurse practitioner and that sort of thing. So there is quite a bit of flexibility. Many include at base like an LPN, a nurse, MOA, and then the rest kind of can vary greatly. And so those service plans, many are now complete, and many more are just coming up to be approved, and they all do look a little bit different. And again, that is what was requested, because we understand that all of the regions, as well as the host nations within those regions, are different and may have unique circumstances and challenges that they're hoping can be addressed. And so, so there's quite a bit of flexibility related to medical staff. These contracts look similar to the PCN, but are an alternate payment plan. So different than the fee-for-service models that are out there.
Thank you. Next question from Heather. I'm going to also lump the question with Chris on the chat. Heather asks, is there anything like the Luma Medical Center anywhere near Chilliwack? I think, Terry, you answered about some of the Fraser Health locations. Christopher also asked, who's the First Nations Health Authority contact learn about services and programming for First Nations in the STS corridor? I apologize, I don't know STS, but I imagine it's a region of the province, STS. Maybe I can look that up while Terry, you can respond to the services near Chilliwack.
Yeah, thank you. So there'll be, I think, kind of two that would be in and around the Chilliwack region as far as our FNPCI. So one, Dr. Dumont highlighted was Sta'elis, which I think is closest. It's near Hope. And then there will be the hub and spoke model that I think is going to be operated kind of out of Surrey, but we'll be providing outreach into many different nations on a regular or weekly basis. And then I think there's also talk about how that can collaborate and link in with some of the current services like the Seabird Island Health Center and others, as far as how all these different models can link in to support one another and build upon the work that's already there.
Thank you. And Christopher, thanks for clarification. STS means sea to sky corridor. Is there any who to contact or what type of programming for First Nations along the sea to sky corridor?
So I think that would probably be the Pemberton FNPCI through our Vancouver coastal team. And so there is a central Pamela Grant is our project manager provincially, and or you can link in with our Vancouver coastal regional team as well. Kim Brooks is our VP of that region, and there is a primary care regional manager that helps to support these centers.
Thank you. James asked, Michael and Lisa, for your clinics, how long is there a wait list for Indigenous patients or the family members to access primary care at your medical centers? Michael and Lisa, welcome your thoughts.
Yeah, there is, and it's a little disheartening sometimes, but I think it speaks to why we need to create more spaces like this. There's so much demand. So we have about 2,400, actually about 2,500 now. I think that was older data that I was showing before. Patients that are currently rostered at LUMA, and we have over 1,000 people on our wait list. Currently, we should be able to get to roughly 3,000 patients. I think with our current, with all of our, all of the personnel that are hired, we're just basically bringing new patients on slowly. But yeah, we won't be able to meet the demand of everybody there unless we are able to create a bigger clinical footprint, which means expansion of the clinic, creation of satellite clinics or new PCIs. And I think in the urban space especially, it speaks to just how much need there is out there, and you know, we really need to. I think we've shown that this FNPCI model and this way of developing clinics is a really successful one. I think we need to lean into that further. There are other clinics that are doing really good work in Indigenous health, other nation-based clinics that are doing really good work, and I think this model could and should expand in order to meet that need.
Thank you. Lisa, for the All Nations.
Yeah, we have been open with the soft opening in November, so it's been a year. We too have a wait list, and we've just completed our first year evaluation, and I think it just also speaks to the GP attachment rate and the complexity of so many of our members that walk through the door. And so we are doing some work on that as an organization in partnership with the Ministry of Health. But again, I think it does speak to that safe space that our members are are feeling very comfortable walking through the door. And I also think it speaks to for us in the Williams Lake area, the lack of doctors, right? We have a lot of retiring physicians. And so we are working in partnership with Interior Health Authority as well, with our local hospital. So thank you.
Great, thanks. We're trying to get through all the questions. We may not be able to. I know we only got about 7 minutes left, so I'll try to get as many as possible. And for the rest, we'll try to address later. This next one is from Margaret, and it's about Luma Clinic. But Lisa, welcome your thoughts too. What an amazing clinic. I'm interested in how you organize after hours on call for urgent issues. And does the team regularly meet to reflect on their collective practice? If that's the case, what do these meetings look like and who participate? How do you stimulate those discussions? Michael, your thoughts?
It's a good question. We have a fairly close practice team. I'll answer the second part of it first here. And we are I think as far as that reflection part, like we have regular provider meetings, regular all staff meetings. These are usually in part led by our elders, in terms of grounding us on, in terms of the big picture and what we're doing. But reflecting on practice, I think is a really, it's an interesting question because, I suppose who do we need to think about in that? Is it our, like from a practitioner point of view? Is it from the patient's point of view? I think our elders really help us to sort of ground those discussions with the right point of view and the right mindset. But right now we're doing it mostly through those regular discussions and meetings. We also have several clinic just basically WhatsApp groups, but chat groups, where we can have sort of on the fly discussions for anything that comes up, and we can support each other with tough situations or tough cases, anonymously, of course, but just to help with those situations where we're, are we doing the right thing? Is this the right sort of approach to handle this sort of a situation? We have a lot of issues that come up that are complex to deal with, and it's just really helpful to be able to run that over with a colleague. In terms of the after hours part, we're struggling a little bit with this right now. Certainly trying to meet our requirements is with the college. And what we're trying to do is organize this in a regional way with our I referenced the First Nations Aboriginal Primary Care Network. We haven't felt safe in terms of organizing a call group that with physicians, just from our regional sort of geographic PCN, knowing that our patients are going to be well looked after. We don't want to join a call group and end up in situations where our patients are potentially having visits with practitioners where we're not really certain about where they are in their cultural humility journey, and we're not really confident that they're going to get culturally safe care. So we're endeavoring to build a call group with our First Nations and Aboriginal Primary Care Network clinic members. But this is a challenge right now in terms of actually operationalizing and building that when we've got 8 separate clinics, each on our own independent EMRs. How do we handle confidentiality? How do we handle the sort of the operation of that? Is there going to be, additional staff members needed to be the first contact for the phone lines? So we haven't quite gotten to the point of operationalizing it, but we're having those active discussions. Thank you. Got it.
Maybe we'll do one last question. And again, it's also related to the Luma Center about your sweat lodge. The question is, how can participants or clients access the sweat lodge as do vets? And is it open only to those who are directly connected to the clinic, or is it open to the general public for cultural services? Michael?
We built this lodge, with the support and in partnership with the Metro Vancouver Aboriginal Executive Council. That's an organization that represents many different urban Indigenous organizations that provide social services in the Lower Mainland, as well as Vancouver Aboriginal Child and Family Services Society. as of right now, we're still working on the protocols for how people can engage. You know, we want to be inclusive to all people from all backgrounds, and certainly in terms of you know, diverse identities. There are some protocols when it comes to ceremony that are important to follow, but it's also it's sometimes a challenge in terms of balancing the need for protocol, but also the need for inclusivity, and we're still working through how that'll actually work. So the goal and the intention long term is certainly for people to be able to access this, you know, from the community, not just for patients that are registered to the clinic. We haven't figured out exactly how that will work yet, but that's certainly aspirational. But for patients that are already, you know, in LUMA and part of the clinic, then it's through our elders and through the sort of our spiritual support team and elders helper. We've unfortunately just left our clinic. We had one staff member who had to leave that would normally be handling that sort of thing, but we're hiring a new person in that role.
Excellent, thank you. Maybe for a last minute, I'll go back to Terry or Lisa. Any kind of concluding thing, or the overall kind of amazing that you share your governance and the whole piece. So I want to make sure that we hear your last thought before we close. Terry.
Yeah, thank you. And I'll definitely hand it over to Lisa to close. And just wanted to thank everyone. And if we can maybe steal a minute, and if you're okay to speak to it, Lisa, just a little bit about the FNPCI governance. And I feel that you know, that's a really important, powerful part of the, you know, how these centers come to be and how they're operated. And it was one of our final questions, but thank you, everyone. And we can definitely share the slide decks. I think that's okay, with some contact details if people do have additional questions. So thank you, Chalia.
Yeah, thank you. And just in terms of FNPCI governance, each region has a specific governance structure. So for me, we have 7 nations within the interior region that hold the traditional territories in which we acknowledge before and on these calls. And so those governance structures are a part of these FNPCI. So for me, I have the 3 nations that sit on those governance structures with technicians. So that's how ours operate. But if I'm to close with anything, you know, this truly is, in my lifetime, I never thought I'd see a facility, and we are a net new facility. And this elder, when we first walked in, said, this is a dungeon. And for us as First Nations people of this land to have a facility that's equitable to our partners across the street, and that quality care, that quality safe care, that's true reconciliation in my eyes. And I take my hat off to the Ministry of Health for recognizing that and acknowledging that need for our people. The statistics speak for itself, and for us to have that care equal to anybody walking across the street is so incredible, and it's been such a great journey. So thank you for your time and participation today, White Limlim.
Wow, thank you so much. I really want to thank Elder Doris, thank Terry, thank you, Lisa, thank you, Michael, for excellent panelists. Really want to thank everybody for being here, and also really allowing me to kind of witness not only the 10th birthday of First Nations Health Authority, but also the growing organization, and how do you bring organization to support traditional practices, support our community members, and just amazing work. Thank you so much for this sharing. Thank you very much, everyone. I wish you a wonderful holiday season in December, and we'll see you again next year. Thank you so much, everyone. Take care.